on the efficacy and safety of dual direct current cardioversion versus single direct current cardioversion as an initial treatment strategy in obese patients with atrial fibrillation.
Good morning, y'all. My name is J.Aymond. I'm an electrophysiology fellow at Ochsner Health in New Orleans. I'd like to thank the AHA for inviting me to speak today. Today I'm going to talk about the efficacy and safety of dual direct current cardioversion versus single direct current cardioversion as an initial treatment strategy in obese patients with atrial fibrillation. I have no disclosures. If we look at the incidence and prevalence of atrial fibrillation and obesity, they're both on the rise. It's estimated that 1 in 4 adults by the year 2030 will have a BMI greater than or equal to 35, and 6 to 16 million adults in the United States will have atrial fibrillation by 2050. Both obesity and atrial fibrillation are very closely linked to one another. We've seen that obesity can increase your incidence of atrial fibrillation as high as 50%, making this a common clinical scenario encountered by providers. In patients who have atrial fibrillation and a rhythm control strategy is pursued, electrical cardioversion is typically the treatment of choice. However, obese patients fail cardioversion more commonly. With 20 to 35% of obese patients, our cardioversion techniques are failing, versus less than only 10% of non-obese patients. This is thought to be secondary to increased transthoracic impedance and possible left atrial size. What we've also seen in the literature is that there's a higher success rate with higher shock energies, and this is thought to be secondary to increased current density at the atrial myocardial level. So is there an alternative cardioversion modality? If we look at our conventional single cardioversion, there's a single set of pads with the more opaque pad being on the anterior chest and the more transparent pad being on the posterior flank region. And between the set of pads, electrical energy is delivered. For dual cardioversion strategy, we have the same set of pads with electrical energy being delivered. We also have an alternative pad, and the electrical energy flows between this set of pads. And in this demonstration is kind of a crossing fashion. These shocks are delivered simultaneously. What we know about single cardioversion is that an initial high shock energy is recommended, and this was discussed in the 2014 guidelines, and an upper shock energy safety threshold is unclear. For dual cardioversion, I'll show you a video quickly. Here we have 2 Zoll R-series defibrillators that are being charged, patients being paced in atrial fibrillation. We're synced to the QRS. We wait for both defibrillators to complete charging. We then push and hold both defibrillators to deliver 2 simultaneous shocks. Dual cardioversion is twice the shock energy delivery, which is a higher current density at the atrial myocardial level to overcome the defibrillatory threshold of the atrial myocardium. What we've seen in previous trials is that this seems to be a safe and effective modality, but has only been studied in cardioversion refractory atrial fibrillation. Its use as an initial treatment strategy in a population such as obese patients known to fail this traditional strategy is unclear. The purpose of our trial is to see if dual DCCV is a more effective initial treatment strategy compared to single DCCV in obese patients with atrial fibrillation. This was a multi-center randomized patient-blinded control trial in 3 centers in Louisiana from August 2020 to August 2023. Our primary outcome was restoration of sinus rhythm regardless of duration, immediately following cardioversion. Our secondary safety outcomes were post-cardioversion tachy and bradyarrhythmias, chest discomfort, which was assessed by the patient on a scale from 0 to 10, stroke, MI, and death. We included patients that had atrial fibrillation, a BMI greater than or equal to 35, which is class 2 and 3 obesity, adults, non-emergent cardioversion, and adequate anticoagulation. We excluded pregnant and incarcerated patients in this trial. To determine our sample size, we reviewed previous literature and estimated a 75% efficacy in single cardioversion versus a 90% efficacy in dual cardioversion, which estimated a patient size of 200 patients for an 80% power. We randomized our patients in a one-to-one fashion to single or dual cardioversion. In patients who were in the single cardioversion arm who succeeded in first shock, they had completed the trial. The same goes for the patients in the dual cardioversion arm. If patients in the single cardioversion arm failed their first cardioversion attempt, they were then subsequently cardioverted with dual cardioversion strategy. Patients in the dual cardioversion arm who failed their first attempt were also shocked subsequently with dual cardioversion strategy, and both cohorts were allowed up to 3 total attempts or at the discretion of the treating physician. We assessed 2,079 patients with obesity not meeting criteria as the most common reason for exclusion. We randomized 200 patients. 101 were assigned to the single cardioversion arm, and 99 were assigned to the dual cardioversion arm. If we look at both of our cohorts here, both were fit with 2 sets of pads. Once again, the opaque pad is on the anterior aspect of the chest, and the more transparent pad is more posteriorly. We asked providers to not apply any pressure to the pads to homogenize the cardioversion, and to not time them off of respiration either. In the single cardioversion arm, this set of pads was not utilized for cardioversion. However, this set of pads was. In the dual cardioversion arm, we use that same set of pads to deliver a 200 joule shock as the single cardioversion arm, but we also utilized our secondary set of pads for a 200 joule shock to total 400 joules. Our patients were well matched between both groups, with a statistical anomaly of our single cardioversion arm being a little bit older than our dual cardioversion arm. Our average BMI for all comers was 41.2 and well matched, and our medical history was well matched between our patients. Echocardiographic parameters that we assessed was left ventricular ejection fraction, as well as left atrial size, which was well matched, as well as medications, and specifically antiarrhythmic drug use. Our outcomes showed that patients in the single cardioversion arm failed cardioversion 14% of the time, versus only 2% of the time in the dual DCCV arm. This was statistically significant with a p-value of 0.002. To further assess cardioversion failure and modality utilized, we did binary logistic regression. Our univariable analysis showed an odds ratio of 7.8 with a statistically significant p-value. We also performed multivariable analysis with a pre-specified covariance age, sex, BMI with an odds ratio of 8.5. We performed a more comprehensive multivariable analysis with a pre-specified covariance, as you can see below, which showed that single DCCV was 12.6 times more likely to fail compared to dual DCCV. So what happened to our patients who failed their first cardioversion? In a single arm, there was 14 patients. Of that, on the second attempt, 12 to 14 patients succeeded cardioversion, which was with dual DCCV strategy. 2 patients had failed. A third cardioversion attempt had successfully cardioverted these 2 patients who had failed their second DCCV attempt, with 100% of the patients who failed single DCCV succeeding with subsequent dual cardioversion strategy. We had 2 patients in our dual DCCV group who had failed their initial shock attempt. 1 patient had succeeded on their second attempt, the other patient had failed. The treating physician made the decision to not try any further cardioversion attempts. We had loaded him on amiodarone, brought back 2 weeks later, and successfully cardioverted with dual DCCV strategy. There were no difference in post-procedure chest discomfort between patient groups, and there were no procedure-related adverse outcomes. Limitations of our trial included that this was a provider unblinded trial. Only patients were blinded to their treatment assignment. There are no long-term outcome data, and this was only a single pad orientation, and certainly other orientations of pads could have been tried. So in conclusion, obese patients with a BMI greater than or equal to 35 undergone electrical cardioversion for atrial fibrillation. Dual cardioversion is more effective than conventional single cardioversion without an increased risk of complications or discomfort. I would like to thank all of the authors especially Dr. Daniel Moore, who has been my mentor for the past several years on this trial. I'd like to thank Sequel Coordinator, our research coordinator, our lab staff, and most importantly, my wife, Morgan, who has been with me every day on all my academic endeavors. Thank you.